to one and all. I, Dr. Asavri Sawant, welcome you to the Rapid Roundtable, an initiative of Integrated Health and Wellbeing Council and Rapid Global Cancer Alliance. The topic for this roundtable discussion is the vision for cancer care in India. This topic, Vision for Cancer Care in India, is aligned with the World Health Day 2023 theme of Health for All and aims to develop a comprehensive cancer care system that ensures access to affordable and quality cancer care for all. To deliberate the same in great detail, we have some eminent experts here with us today. I welcome Dr. Shibu Vijayan, who is the Medical Director of Global Health Practice at Cure AI. Sir, we welcome you to the show. We welcome Mr. Vineet Gupta, who is the Director for Government Affairs at Variant Medical Systems. Sir, welcome so much.
Thank you so much.
We welcome Dr. Ratna Devi, who is the CEO and co-founder for Patient Academy for Innovation and Research and chairwoman for ISPOR, Patient Council, Dakshama Health and Education. Ma'am, welcome to the show.
Thank you.
We welcome Dr. Venkata Pradeep Babu Koyal, who is the lead for medical oncology and principal coordinator with medical member-elect credentialing committee and research cell at Assam Cancer Center Foundation. Sir, welcome to the show.
Thank you, Dr. Sawant.
We also welcome Ms. Neerja Reddy, who is the Vice President of Genetic Counseling for Map My Genome. Ma'am, welcome to the show. Now I hand it over to Ms. Neerja, who would be moderating the show.
Hi, everyone. Good evening and welcome to this Rapid Roundtable. It's my pleasure to moderate this wonderful session, and we're looking forward to thought-provoking conversations today. So, as we all know, cancer's prevalence has been increasing, and more people are identified with cancers due to changes in our lifestyle, as well as better detection and early diagnosis. Now, we want to work around reducing disparities and providing care that is equal for all. So today's conversation is going to be around this. And I will first welcome Mr. Vineet to share his thoughts on a couple of very important discussions around what is happening at the government front. So Mr. Vineet, if you can first share some discussions about what kinds of infrastructure is the government building for cancer care, especially to provide an affordable cancer screening as well as prevention program that is not limited to the urban centers in India.
Thank you, Neerja. Thank you for this opportunity. And, cancer, as we all know, the disease burden of cancer in our country is immense today. Almost 1.4 million new cases are added into our country. And we lose almost about more than 800,000 people due to cancer every year in our country. Now, this requires some kind of creation of an urgency from the government side, to address this disease. And we are very sure that government has that wherewithal to address this disease burden, because we have seen government to kind of move up so fast and rapidly when COVID struck the country. So government had done a great job, to combat COVID as a disease. And I'm sure similar things can be done, by the government for addressing cancer as a disease burden in the country. When it comes to majority of the cases of cancer are still detected at stage 3 and stage 4. We are all aware of that. And that is largely due to the, people not getting screened, as a measure of prevention, or so it is not one individual or one segment of the society which is probably responsible for the screenings and the early diagnosis not happening. We have, government has got, I would say, complete plans as part of the NCD diseases, as part of the NPCDs program, where the guidelines for screening and early detection are clearly defined. Now, with the health and wellness care centers coming up under the Ayushman Bharat scheme, the screening facilities are being created at the rural level also. However, there is a societal aspect also, which probably prevents people from not going or not taking initiative to go and get themselves screened for these kind of diseases. And I think maybe some kind of an IEC program, some kind of an engagement from the patient groups, or all these things can definitely help, in increasing awareness about the importance of early screening and getting, ourselves tested and screened for these diseases. So that is one aspect. And trust me, this is not from a rural sector point of view. I'm saying this is across the country. I mean, I know, within my families, I know so many people, even from the doctor fraternity, people are not willing to go and get themselves tested. Unfortunately, that's one part of it. The other part is about the overall cancer care infrastructure, which I want to talk in the country. We all know that there are three pillars, for cancer treatment, largely based on surgery and chemotherapy, or the medical oncology, which is known, which is commonly known as chemotherapy. Most of us are aware of it. Even the common person is aware of it. The third pillar, which is the radiotherapy, is definitely not known so widely as the other two, as part of the cancer treatment. And why it is so is because radiotherapy in our country, if you compare the global figures, from the developed countries, 50% of the cancer patients are actually given radiotherapy treatment as part of the treatment cycle. Whereas this figure in India is almost around just about 18 to 20%. And largely the reason is that the facilities for radiotherapy centers are far and few. The WHO guidelines suggest that we need to have, let's say, one radiotherapy machine or linear accelerator per million population. We are a country of 1400 million population, whereas we only have just about 700 machines functioning in the country today. So that means we are short of at least 700 machines while we are talking about. Plus, there is an addition of population, retiring of old machines. So we at least need 100 odd, at least almost about 200 machines per year for next 5 years to be able to attain the WHO standards. If you talk about the geographical skew, these machines are largely available in the private sectors. 85% of them are available in the private sector out of 700. And the geographical skew, which I'm talking about, just about 120 districts in the country has got this facility, which means we are talking of out of 740, we are talking of only 120 districts, which is just not even 20% of the total, from the geographical point of view. So there is a huge challenge for people to go and get themselves treated, because people have to go, at least 20 times, 25 times, depending on the severity of the disease, the fractions they are given accordingly. And if they have to move from their, hometown to a new city, majority of the patients are not able to fulfill the treatment, complete the treatment, because the cost burden is so high of shifting to a new city, leaving your current income, spending into a new city, and then getting the treatment done. Even for that matter, in the government hospital, people are not able to get it completed, and they have to go back. So the point I'm trying to make here is that from the government side, I think for last good 5-6 years, we have been working in this space, both at the federal level, central government level, as well as the state level. With central government level, we are trying to push for a holistic program around, creating a cancer care infrastructure to target about, let's say, around 250 to 300 districts in next 4 to 5 years, where we can, earmark the district hospitals to have these kind of facilities. We can then think of localization of the technology also. If there is some kind of a commitment from the government side that would actually kind of meet the government's vision of Make in India also, we can also create a skilling program for the technicians, for the medical physicists, for the doctors also, radiation oncologists, doctors also, to get acquainted with the latest technology. Because today, unfortunately, we are still stuck with cobalt technology, which is definitely not a technology which can give treatment. It can only help, the patient to live last few months or few days in a peaceful manner, in a better manner. Otherwise, cobalt technology doesn't treat the patient from a radiotherapy point of view. So all these things, can be brought in as a larger program if the government can create this kind of a program. We've also been engaging with the states to seed the concept of setting up radiotherapy centers on public-private partnership-based model. Now, We have seen a success of PPP models in the space of radiology diagnostics. We have seen it in the space of pathology diagnostics. Even in the space of treatment, we have seen dialysis. And in the nephrology space, the PPP projects have been fairly successful. The government also has come out with a policy documents on these things. As of now, we don't have a precedence for a PPP based model for a radiotherapy center, except one at SMS Hospital in Jaipur, which is currently running since 2008. But unfortunately, that is the only model which has been working till now. Rest, there is no state which has got this kind of a model being run. Secondly, however, the challenges are very different from, let's say, a radiology setup or maybe a pathology setup, because one, the patient has to come time and again. The cost of setting up a center is also a challenge. So we have been trying to figure out the possibilities of viability gap funding from the central government to fund these kind of projects, so that more and more players are willing to be part of such kind of projects. Unfortunately, the corporate hospitals haven't shown much interest because their plate is full. Their plate is full in terms of treating the patients and the kind of patient load they are getting in their existing facilities. However, there are a lot of players. If they get some kind of a VGF support in tier 1 and tier 2 towns, they are willing to come into this space, even to treat patients on the Ayushman Bharat rate, which are the benchmark for these proposed PPP projects. So I guess this is still a work in progress. The good part is that the government has now started thinking on these lines. The needle is surely moving in the right direction. Last year, Ministry of Health organized a day-long conference as a roadmap for cancer care in India. So a lot of things are being discussed, and we are hopeful that soon we will see some activity both at the state level as well as the central government level to ensure that we are moving in the direction of increasing the overall cancer care infrastructure in the country. Thank you.
Thank you, Dr. Vineet. I think you've touched some very important points. One, that we definitely need more private and public partnerships. So one of those things is to, expand in that direction so that we can offer better care for people. What are the policies or what kinds of strategies are put in place for also standardizing the costing and affordability? Because I think one of the major issues that you also highlighted right now is that the cost is very, high, and it becomes more challenging when people have to travel long distances. So of course there is disparities due to geography, but what about costs otherwise? I mean, there's definitely a huge difference in costing of what is offered in a government setup versus a private setup. And is there any sort of a cap? I know for COVID testing we had done this, the government had done this. Is how can we cap or standardize some of this costing? So what's the efforts from the government side?
No, it is difficult for us to expect government to come out with scheme where they are able to cap the treatment charges, especially in the private sector. Any which way, the treatment facilities are far and few today in the country. However, we have seen that government has come up with another alternate method of Ayushman Bharat scheme, where they have clearly identified that there is surgery processes covered under Ayushman Bharat scheme, medical oncology processes, and so is radiotherapy treatments. So they have given multiple I would say multiple rate list of radiotherapy treatment with different fractions and everything. So the point is that today, setting up of radiotherapy center or people who are already giving cancer care treatment to the patients, they are not able to embrace the Ayushman Bharat rates, because largely the hospitals which are providing these services are corporate hospitals. So we see very little participation from standalone hospitals or maybe tier 1, tier 2 hospitals. Assam, when Dr. Venkata Pradeep Babu is here and part of Assam Cancer Care Foundation, and we have been associated with this project as an organization provider of the equipment there. And I can say that, the central government is now urging the states to look at the Assam model also. I mean, of course, there was a 50-50 partnership between Tata Trust and Assam government to form this Assam Cancer Care Foundation. Now they have set up some 17, 18 centers across the state, giving different levels of services depending on what kind of an institution is and what kind of area it is covering. So this is definitely a model worth emulating, and states are now being encouraged by the central government to look at this model and try and emulate in the best possible manner there also. However, the challenge is, I mean, Tata Trust initially started with a vision of setting up similar 400 such centers across the country, but unfortunately with the change in their leadership, the focus got diverted and diluted, and then now it stopped with Assam as a state only and couldn't go beyond.
Understood.
So we
Understood.
certainly need more players like Tata Trust or other agencies, similar agencies, who can then participate from a funding point of view, because funding is a huge challenge, and
Correct.
it is very difficult for individuals to kind of scale up the models, for the kind of services we need across the country. So for individuals, it is definitely not possible to scale up the way we need it.
Makes sense. Thank you. Thank you, Mr. Vineet, for very insightful discussion here today. One of the points that you brought up is, it's just not the society or the government that can push for better screening and more, or for people to be, conscious about the cancer screening that we have to do. So taking that forward, Dr. Ratna Devi, I'd like to ask you about what are the disparities that you think, from your practice and your experience that you see are the most common reasons or disparities in care essentially for cancer, and what kind of innovative solutions can we identify to resolve these?
Thank you, Nirja. And I'll just build on what Mr. Gupta said about the financial and geographical disparities, and they are very, very apparent in spite of an Ayushman Bharat scheme, because even states have adapted or adopted that at various levels, and there are certain states that have not even adopted it. Again, when you go to state government, private sector, if you have an insurance, you might be covered. If not, you pay out of pocket. But even within the government systems, in say, for example, the national capital of Delhi, if people from the neighboring states come here, then the state hospitals do not accept them. You need an Aadhaar card or a voter ID to be able to qualify for free treatments. And that becomes, patients don't know this. They just know that there is a hospital which says it's a cancer treatment hospital, and they come with hope. And then they wait outside the OPD for 3 to 4 days because these hospitals are so full. And after 4 days, they are said, okay, you're not eligible because you do not belong to the state, and which is completely heartbreaking. We have counselors in these hospitals, and this is what we keep hearing time and again. The other thing is, even within these hospitals, not all hospitals are at the same level of care. So, for example, within National Capital Territory, there is one hospital that does not have a CT scan or an MRI and refers patients to another state hospital to get those tests done. And the waiting time for that is 1.5 months. So, cancer being such a time sensitive disease, imagine asking a person who is reported at stage 3 to wait for 1.5 months. So they're forced to go outside and get it done on their own, or simply, allow the disease to progress. And these are very visible gaps within the program or the systems that are currently existing with no solutions. I don't know why state governments are not talking to each other. So within one state, probably the state machinery is working well, but as soon as the person crosses the border, and we know that people are moving from one place to another because of jobs, migration issues, etc. As soon as the person leaves their hometown, they are pretty much left in the open because they don't get the services, even though they might be enrolled for the Ayushman Bharat card. In terms of disparity, there is very low health literacy, and therefore people, do not understand the initial signs and symptoms of cancer, and they try and manage it with home remedies or with local practitioners who might not be qualified until it reaches a level where it cannot be treated anymore. In terms of radio diagnostics, we know that again, things like CT scan, PET scan, etc., are available only in the big cities. Even though there are other programs under the national NCP-CBS program where CT scans are made mandatory at district hospitals to treat stroke, but you still don't find those scan machines. Or if those machines exist, there are no human resources. That's another big problem in many of these hospitals, that you do not have trained counselors who can sit with the patients and help them to understand why it is important for them to continue with their treatment, come for regular checkups, and not give up therapy in the middle. So we find many patients who have been diagnosed, started on treatment, and they simply disappear off the grid. And we don't know where they've gone. Either they've gone to some alternate medicine healers or some kind of spiritual leaders. So they go because they lose hope, and they are so frustrated trying to navigate the system that they simply find it easier to go back to their hometowns and manage in alternative means. We do have a national cancer grid and a registry, but it still does not capture all the information. All the true burden of the disease is still unknown. And I think that a lot of awareness has happened, but still more needs to happen. So, for example, in breast cancer, cervical cancer, and oral cancers, because of tobacco prevention, there is fairly good awareness. And people do know that if there is something happening in the mouth or the breast, you are supposed to report. But for other cancers, there's absolutely no awareness. And I think those areas also need to be covered. In terms of the myths and misconceptions amongst patients, there is this general fear that once you're diagnosed, then death is a surety, whereas many cancers are treatable. So I think that fear and stigma needs to be removed so that people continue with their treatments and don't give up. In terms of financial burden, even in hospitals that assumedly give free treatment, there are a lot of treatments that the patients have to pay for. And that is an additional burden which sometimes patients are unable to manage. Also, when patients migrate to these cancer hospitals, they migrate with families. So even though the treatment per se might be free, there are a lot of additional costs in terms of accommodation, food, etc. And there's no support for this. So some kind of support, and like Mr. Gupta said, if there are Tata Trusts or other such philanthropic institutions, in the same way that you give nutritional support for, say, tuberculosis patients, if there is something that can be provided for cancer patients as well, because the chemotherapy is hard to tolerate without proper nutrition. And many of these people are so impoverished that they are not able to tolerate chemotherapies. And that's the reason why they give up after the second or third cycle. And, it's only when it progresses beyond treatment stage that they actually come back and they are then very desperate. So a lot of awareness needs to be done around treatment opportunities, where it is available. A lot of patients don't even know where it is available. So they move from one hospital to another. And by the time they reach the right hospital, they've already lost a lot of time. So where are these hospitals that provide cancer treatments? And not all hospitals provide cancer treatments for all cancers. So, which hospitals provide treatments, which are the ones that are specialized in advanced therapies, etc. How can patients, book appointments? So use of technology without actually waiting in long queues and moving from one hospital to another just to find out if there is a bed available. So bed availability is a big problem because many of these hospitals are filled to capacity. They don't have any beds left for new admissions, and that is why patients are waiting out on the street. So if there could be some system where you can connect these hospitals to allow us to understand which hospitals provide the services that are required, and how can people make online bookings or appointments so that they can go straight to the place which is ready to receive them instead of waiting for weeks and months. I think it would be a good and proper solution. So I think
Absolutely.
apart from everything, technology could be a game changer.
Yeah. Yes, Mr. Vineet.
I fully concur with Dr. Ratna Devi. 2 points which I just want to take, for a common man today on the street, cancer means almost a death sentence. That's how the cancer disease is perceived today. So somewhere we need to, instead of that fear of cancer, we need to create a hope against, that, okay, fine, we can fight this disease. That is one aspect. That's a psychological aspect which I'm talking about. However, we have seen in the past that we have been able to create a technology through which anybody and everybody on the street is aware of a disease called COVID through Arogya Setu app. So if something like these can be done for disease like cancer, then at least a common man would be at least aware of how many of the cancers can be prevented just by a better lifestyle. What are the consequences once the cancer is detected, what needs to be done. So all the points which can be covered related to the cancer before the disease happens and after the disease happens, so that everybody on the street, if gets that kind of an awareness through an app, because everybody has a phone today. I mean, the penetration of mobile phones, smartphones in India is probably the largest in the world, I would say. So that can certainly help bring down the burden of the disease in the country. And one last point which I want to bring, we had early 90s, late 80s, we had fought the disease burden of AIDS in our country, and NACO was formed for that. So we need an organization like NACO to deal with the cancer disease as a burden today. I mean, because today everything is so fragmented. Government says we are giving money for setting up state cancer institutes. We are giving money for setting up tertiary cancer care institutes. Now the problem is that the time a state cancer institute is announced and by the time it is actually functional, clinically commissioned, the time between them is almost about a decade, almost 10 years. So who is looking after that gap of 10 years and where the patient will go and then get them treated? I have seen cancer, institutes which are centrally run cancer institutes. They take about 3 to 4 years for procuring a leader accelerator for their centers. So who is responsible for these kind of, even after the vendor is finalized through the tender process, the signing of the file can take as long as 1.5 to 2 years before the physical order can be placed. And the machine will then take 7 to 8 months for the machine to come and get clinically commissioned. So, I mean, somebody has to take that responsibility of the gaps, the time lapses, and we need to plug in those things. Probably a NACO like an organization, a creation of an app like Arogya Setu. These may be some answers to some of these problems which we face on a day-to-day basis.
For sure, Dr. Vinita, Mr. Vinita, I think COVID has been a great example, and the organization and management of how we have been able to come out of it has been a great example from the government. Definitely a lot of lessons to be learned in cancer care from COVID. Dr. Ratna Devi, what about your insights on how can we build a better patient support group? One of the things that I find in my practice as a genetic counselor is that patients often find themselves being extremely isolated, especially for the rare cancers. They also find that, like you said, the stigma is very high. They do not want to speak to their family members. They find themselves, asking questions of why me, what happened, what did I do wrong. So I think there's a lot of support that can come from the patient support group. So what, in your experience, how can we help them build a better patient support group?
So in the cancer space, there's already a lot happening as far as patient support groups are concerned. There are about 110 patient support groups in India itself, small and big, national, local, some working just at the district level. However, they are not under one umbrella. So each one is doing their own little bit and not learning from each other's experiences. So if there could be some mechanism to bring all of these into one umbrella, it could be a very strong force that could probably contribute to the narrative at the policy level, as well as this awareness generation activity, etc., that we are talking about. Again, within those 100 odd groups, the breast cancer groups are the strongest, and they have a national presence, and they are very well connected to international groups, etc. The other cancer groups are doing a little bit. The rare cancers, there are 3 or 4. But again, they're not very visible, possibly because, cancer is such that the person who becomes an advocate possibly dies, and then it's a family member who takes the whole initiative forward. So if the family member is passionate, even after the person has died, then the movement moves forward. Otherwise, a lot of cancer groups start because there's a family member who suffered, and there's a spouse or a sibling or somebody who's supporting it, and then this person dies, and then that enthusiasm goes away. So it is not sustained. And if there is some way we can bring all of these people together, then there is some work happening that we can build on instead of reinventing the wheel all over again. And in terms of rare cancers, depends on what kind of rare cancers you are looking at and what kind of disease burden exists in the country. If there are very small number of patients, then creating a patient group becomes a very big challenge. What we normally do for rare diseases is to look at the larger umbrella and then work with specialists from the HCP fraternity to be able to gather those patients and bring them together. If there is a specific ask, I mean, why do you want the patient groups to come together? Either to know that there's a new treatment or therapy available, or if it's not available, how to get it into the formulary, government formulary, or get it supported by some kind of financing mechanism, or get it registered into the country if it's not yet available. So if these are the 3 asks, then we can get these 50, 60 patients together working with the physicians, because they're the ones who identify the patient, and then create a charter that we can then present to the government. And trust me, the government now is very supportive. They listen to us, they call us for all meetings, and they're very, very supportive. So it's not so difficult. The difficulty is to work with the physicians and to get them to agree that there is this need that needs to be addressed through the patient voices.
Correct. Thank you. Thank you, Dr. Ratna Devi. Definitely sounds hopeful to see that, we may be able to reduce a lot of these disparities. One common theme I hear here, definitely here, is that, to have that cross learning from various channels, whether it's between different states, different, government organizations, or even within, patient support groups. So I think that's something that definitely is a need of the hour. Dr. Venkata, I have some questions for you in terms of research. So I know that cancer research, of course, has been growing immensely, but it's also the need of the hour right now. So what areas do you think, where India needs to focus the most in terms of cancer research? And this also comes in the light that just yesterday we saw this exciting news of a new gene being identified associated with an inherited breast cancer risk after, I think, many, many years. And that definitely got all of us in genetics pretty excited, because there are many families in India where, there's a very strong history and we can't identify the gene. So what do you think? I mean, there's definitely a lot of gaps in terms of one, understanding what the mutation profile is, what the prevalence to begin with in India is for various cancers. So where do you focus? What do you think are the areas of focus, especially in cancer care right now?
Yeah, good evening, Nizja. Thank you for having me here. So, before starting answering that question, I completely concur with the opinions of uh, Mr. Gupta and Dr. Ratna Devi that most of the just establishing the cancer hospital is not enough, because I am working in a peripheral area where I encounter very peculiar cases. Uh, because sitting in metros or cities and practicing is a relatively easy thing, because we have everything in place. I just need to ask the patient to go to adjacent building or the same different floor of the same building to get an investigation. But sitting in a peripheral area, even to get a small investigation like biopsy, it's quite challenging. And particularly to get the quality report, services like pathology, where based on which the entire treatment is planned, radiology services, and all these things. Before answering about the research, I just want, if you allow me to share the screen, I just want to show a picture. Today,
Sure.
I clicked the OPD, which reflects the opinions of all the speakers.
Yeah, I think you're able to share the screen.
So this is a lady coming from 30 kilometers from Tejpur, where I practice. She came with deeply fungated ulcer in the breast, almost occupying, the lesion is occupying the entire breast, and it is covered with a bunch of leaves. So I'm stopping the share. So on one aspect, we are talking about immunotherapy, we are talking with the advancements and genomics. On the other hand, we have population who are not aware of what to do when there is a lesion in the breast. And breast is such a superficial organ which, if it is any growth, if it is more than 1 centimeter, that can be recognized. So when we are actually getting such patients with a deeply fungated ulcers going into the chest from the breast wall, so there is serious deficiency in making the people aware that to approach the health services. So in that manner, I completely concur that more than any research, what we need is the awareness, a center in the district where patient can immediately go when there is a suspicion or the doubt of cancer and can ask for the services, and they can be referred from there based upon their interest to either government or private facility. Only when the patient has such information, then more and more patients will be diagnosed in an early stage. Otherwise, we're going through the very complicated network of the physicians and doctors system with various alternative medical systems that are in place. Patients, and that is the reason why most of the patients are being diagnosed in very, very advanced stages. And coming to the two important aspect of question, that is what aspects of research we should be needing in India in with pertinent to oncology. After practicing for 2 years here in Assam, I personally feel that the two important aspects we should focus on, particularly as a low middle income country, which we call as LMIC. One is regarding the epidemiological data. Although we have big databases like ICMR database and NCDR database, which focuses predominantly on the hospital-based registries and population-based registries, there's so much data we are actually missing upon. We should focus on those research where there are hotspots of cancer. Why is there any reversible cause of cancer in those areas, because we know that 50% of cancers may be oral, breast, or other cancers like esophagus, particularly in SM, which is very, very common. My OPD begins with esophageal cancer and ends with esophageal cancer, which is very sad to see, because I am still searching for the patient who does not chew betel nut and is diagnosed with esophageal cancer. I can see the relation between the betel nut and esophagus, but I cannot say that betel nut is the cause of esophageal cancer, because they need epidemiological studies.
Right.
Only when such large studies are conducted, then we can attribute that particular betel nut is causing the esophageal cancer, and we can, at a state level or at a regional level, we can say that it should be stopped or eradicated. And is it very difficult? No. We have Indian Statistical Institute. We have several organizations that are working in isolation. The problem is these institutes, they do a lot of research in one topic, they publish it in very big journals, and they will be happy. But unless there is a concept of interlacing all the research work and talk to each other, the research will never come to the bedside. It will be on bench side only. This is one epidemiological data, because I will give two examples before moving on to the second part of the question. The esophageal cancer, which I mentioned, is probably the highest in the entire India in this part. The squamous cell carcinoma, and it occurs in very, very young age. And it is almost directly related to the quantum of the betel nut they chew, because it is a cultural factor in Assam. Second most common cancer we encounter, which is quite rare in other parts of the India, like South India. In North India, still we see, that is gallbladder cancer. So one of the most important problem we encounter is most of these patients, they undergo, whenever they encounter pain, they undergo ultrasound, there will be some small stone, they undergo simple cholecystectomy. The histopathology is sometimes not even collected, and later on they present with the increasing mass, or they present later with the biopsy report, which says that it is a malignancy. Now that the patient needs a second surgery. By the time most of the patients have exhausted most of the financial resources. Regarding the PMJ, it is a very good scheme. Our hospital operates on PMJ and AAA Atal Amrit Abhiyan for more than 98% of the patients. It is a public-private model, as Mr. Gupta has rightly mentioned, that it is a good example of PPP, and we mostly deal with patients with schemes, government schemes. But even then, there is a problem and challenge of diagnostics, because doing a CT scan, MRI, they are not covered in the PMJ scheme. So for these patients which I have shown, it is still a challenge. The other part which we need to focus is pharmacoeconomics. Immunotherapy, there are nearly 15 types of immunotherapies that I approved till now. And some of the immunotherapies, they are 2.5 lakhs per dose. Imagine how many patients will be affording immunotherapy. And most of these are used in metastatic setting. They are not in a curative setting. So I will not get an opportunity even to discuss also this, because I know that I cannot offer immunotherapy, because that will deprive the next generation of education, health, and everything. So, but a good work is being done by Tata Memorial Hospital, where they are repurposing the approved drugs. For example, there is immunotherapy drug which costs around 2.5 lakhs. Now they have done a study whether it can be used in the lower dose with the similar effects. And these studies were never done in the West, because it is an insurance-driven system in the West. So whatever the dose approved, they usually follow that. They have no necessity to repurpose the drugs. But in India, it is the necessity which drives us to do such experiments, and they have succeeded. I'll give an example. This immunotherapy drug, I will not take the name. This, instead of using 240 mg, it is even effective at 20 milligrams. Now, the cost is cut down by nearly 10 times. It is as costly as any chemotherapy. So it is being used across the country by medical oncologists in the required settings. So these are the sort of research works that need to be done, because although we have capacity to do the end-to-end research in the recent developments, we should focus on the bulk of the disease. The most important thing is to reduce the bulk and incidence of the cancer. That can be only done by increasing the awareness, by repurposing the drugs. We have two issues while we are dealing with cancer. One is to avoid and prevent the cancer. Two is to tackle already diagnosed cases, both of which are very huge in country. 50% of all the cancer burden is from the Asian region. And India and China account for more than 60% of all the Asian cancer burden. So, as Mr. Gupta said, yes, this should be a task force of cancer. There's no doubt regarding that.
No, thank you for sharing some very interesting insights from the research aspect. Definitely, innovation is required in terms of how can we better use our resources and also provide better care to all areas of the country. I know you have done a project called Project Smart Pink, where you had screened about 1,000 rural women. So I want to ask you, and I think the picture that you have shared, the patient is a perfect example of this. Is how do we reduce stigma? See, I think cultural beliefs, faith, alternative medicine, all of these sometimes can also become barriers for our patients to come in earlier. Of course, the fear and stigma exists when it comes to cancer. So, how do you encourage, or what is your, 2 cents in practicing in a rural country? And firstly, congratulations for such a beautiful work that you're doing. I think more and more of us are needed. Definitely motivate me to do that. So what is your experience, and how do you motivate your patients to, be more regular with their screening, come in when they see a sign or a symptom, and how do you reduce the stigma that they experience?
Yeah. Thank you for asking that question. And the project Smart Pink is ongoing project where we are we aim to do at least 1,000 mammograms free of cost. The mammogram cost is borne by the ACCF, Assam Cancer Care Foundation, and Rotary is supposed to mobilize the patients. And we are taking the same opportunity to compare mammogram with a new device called dermalytics. It is a thermal imaging by Niramai. And because thermal imaging, when it is done on the breast, it is very vulnerable when we do manual interpretation. It is very error prone. So there is this artificial intelligence algorithm developed by this company, which is based in Bangalore. And they are giving, after applying the algorithm, they are giving a score similar to mammogram score. So we are now doing a project comparing both mammogram and the Niramai screening. The good thing about this Niramai screening is that this is a non-touch technique, and it is a handheld device. It's a camera sort of thing where we can take this to the interior areas. Let us say this patient has a hesitancy to come, or these family members are. There are some tribal areas who really have difficulty in even if we provide a vehicle to come to Tejpur for a mammogram, because mammogram will need a lot of approvals. It involves radiation. Even if we have a mobile mammogram, that is difficult to take to the very interior areas and to operate there. So this is a device which can be taken to any place. It fits in a hand backpack, and then we can screen the woman based on the. So the project is ongoing. Second, there's a lot of hesitancy for breast cancer screening, because what if something is diagnosed? Just like Mr. Gupta and Dr. Devi has mentioned, even in doctor community, I have persuaded many of the doctor families to come for mammogram, and it is surprising that many of them has not come. The reason being apprehension that something may be diagnosed, and if something is diagnosed, we need to undergo biopsy and all these things. And the most important stigma is regarding the biopsy. I'll give you an example. Yesterday, I was discussing. There's this patient who is suspected case of lymphoma, a type of blood cancer, which needs biopsy to know the grade and to treat accordingly. So I have given the prescription. The next day, the patient attendant comes and asks me if treatment can be done without biopsy. I asked why. Because that elderly gentleman was called upon by his grandson and told that biopsy may cause in severe pain and disease may spread widely. It's already stage 4 disease. When I was seeing him, and then I asked what does his grandson do? He said he is studying 4th class in Delhi Public School. And he saw a video in YouTube and he called upon his grandfather and told, and now he is hesitating to do biopsy, which is a curable disease. Lymphoma, even in some of the stage 4 disease, is curable. See the extent of myths, to what extent myths can penetrate. So I think this very important role of the government to contain such messages, which can be disastrous. And this is a very common scenario. Patients hesitating to do investigations or biopsy, presenting in very, very advanced stages, in immobile stages. In the Smart Pink, along with this one more project that is going on called Project Soundarya, because there is hesitancy to come to chemotherapy. Like Dr. Ratnadevi has said, along with the nutrition, there is a stigma of hair loss. So we have started issuing wigs to the poorer women who are below poverty line, and then so that they can come comfortably traveling in a public transport also for chemotherapy. So I think patient support groups definitely help. So whenever patient is diagnosed and has to receive chemotherapy, what I usually make them to go to the daycare and to talk with the patient receiving chemotherapy. So it's always better to arrange an interaction, because most of the doubts are asked and cleared by them, so that they can confidently come to chemotherapy the next day. So this is what I do and how I encourage the patient to come.
Thank you, Dr. Venkata. I think you're doing amazing work. Please keep up with it, and we hope that more of us, can provide better care to populations outside of urban cities and metros. Dr. Shivu, I want to ask you some questions more around finances and the costs of therapy. Now, I know, for example, immunotherapy is one of the newer therapies that are coming in, and like Dr. Venkata also said, that we are getting more and more of these new therapies and new imaging services, but the cost and financial barriers are extremely, they are the big barriers that the patients are facing. And I think that is one of the reasons why we see a dropout, and why we also see that people cannot keep up with the treatment at all, especially at the end stage. So what options do you find with, for people for funding outside of insurance policies? And of course, what government is offering?
Yeah, so I think pretty much actually we have discussed about what government is offering and then what is the investments in that as well. So I've been associated with creating a health stack which is along with the government airline, my previous stint. Essentially to looking at the, high-end cancer to mitigate the toxic expenditure over and above what insurance is covering. So essentially what we put forward was a non-communicable disease connect, because we don't want to practice that as one thing, because then again, government will have multiple other priorities. And you want to silo one disease or one disease area to be focused. So that's been tackled as essentially connect, wherein it's one part of the solution. I'm not saying that's exclusively solution. That's one part wherein we understand there are certain cancers which require, for example, immunotherapy requires. No insurance will cover that. In the current scheme of things, in the private insurance, it will be difficult to get covered. So this is essentially to derive from the high net worth individuals, the corporates, to make a long-term commitment. So rather than actually for individual patients, and create a pool of resources which could be hosted. So again, the government suggestion was again, don't do it in our platform. The moment you do it in our platform, Mr. Gupta also mentioned about the approval process and the timelines for this thing. So have it hosted under the state society, and have some flexible in approval processes, and keep it flexible, and also rely on the doctor who is deciding rather than on the bureaucracy part. So that is something which we are building on, and in the same time, there is the repurposing of the existing scheme. So that is something which came from the government side. So while you are building this thing, because this is a multi task or a long-term mission, and you are bringing in multiple parties into the conversation, but while you are doing this thing, look at what is existing schemes. So a lot of the schemes cover chronic diseases and debilitated, which is not calling out cancer as a specific disease. So it's probably I wish some of the survivors also need to be part of the panel. So if such groups can actually put pressure, the government can be flexible enough to repurpose that kind of pool of resources to support and mitigate some of the toxic expenditure part. So other one which evolved from the government side, again, looking at from a community, as Dr. Venkata also mentioned about the disparities in proportion of the diseases among the community remain. For example, in Assam it is esophageal, somewhere else it will be something else. So, which is not coming under the, if you look at Ayushman Bharat also, so health and wellness centers covers only 3 basic cancer screenings, right? To start, I'm just saying they cover everything, but again, the cancer screening focus is, I would say, largely skewed towards the female part. Wherein male have lung cancer as common, so it is not covered in any screening program, in at least the government focus. Like they do call out about the importance of screening, but again, at the health and wellness center, which is closer to the community, have breast and oral and the cervical cancer screening. So the idea is to actually look at a subscription model wherein the corpus fund would be coming from a bank. So let's say we go to the World Bank or an ADB or such, or even a state-owned bank, and take a loan in an output-based manner. So I take, let's say, 100 crore and cover a population which is slightly higher risk with a higher premium. I know that this is higher risk. And over a period of time, I do active case finding also. I mean, so that after some time, my wish is I don't want the patient to come to my system to consume all the money from the kitty and then the insurance, fall out. I would have to make sure, okay, so patients are not coming. So the active case finding part, the decentralized screening part for a larger range of diseases, cancer diseases, would eventually, the proposition which eventually not consume the insurance. And hence, after let's say after 5 years or 7 years or 10 years, government will be in a position to pay back the interest, given that the insurance continues. So initially, the initial few years, it's going to be taxing to the insurance, and the government investment will be high. So that's the community insurance model, which is a subscription, which is also going to be a co-payment model. That has been talked there because it includes a lot of local self-government coming in and then they also pooling money. The other part is that we also felt there is a whole lot of organized sector which could be covered under the ESIC, which is not happening. So it's a function of government informing many of the institutions or organized sector which falls under the ESIC mandate. We need to mandatorily enroll them in this. So we all mentioned about like the hesitancy from outside in doing and getting screeners. So none of the professional organization, none of the corporate sector cover as cancer screening as a mandatory offer to their employees, which is easy, right? So bulk of the population who are actually working in the corporate sector, they can afford to have. So I think these are something which evolved from this. And there are specific schemes for pediatric population, which is, most of the pediatric cancers are curable. And which also need a lot of investments. So the pediatric, they are not, again, that is not called out as a specific pediatric cancer care fund. There are pediatric, less than 18 years, supportive funds are there for chronic diseases, rare diseases in the pediatric population. Can we include cancer in that? So I think these are the options which came out of from that brainstorming, which it actually had economists and health economists coming and sitting in that. So that's my take on it. So one thing which we are probably maybe not talked about it, and I understand that it's also been used in Assam from a lung cancer perspective. Also, there's a vested interest in why I'm saying that. So the organization which I am representing is also working with artificial intelligence for detecting, for enabling X-ray reading, and we have a solution for nodule detection, early nodule detection. So X-rays, almost 3 billion chest X-rays are taken in this country. And it's a matter of like using technology to indicate if there is a nodule coming in, then it's a care pathway. So we are latching on in Vietnam, in Assam, in one hospital, we have actually done using AI reading for early detection of nodule. And lung cancer is the commonest among them. So this is something which is, I think, technological advances. So, Dr. Venkata mentioned about Miramai and the AI for the breast screening, scanning reading. So similarly, eSanjeevani is another platform. So probably the initial consultation, Mr. Gupta also mentioned about empowering and upskilling. So one part of it is like we now have eSanjeevani. We now decentralized. If you look at like health and wellness centers are also being envisioned to be decentralized care. The PHCs are coming, as being infrastructures. so 15th Finance Commission from the Government of India is an infrastructure investment going to the states. So this is the right time to probably policy level influence and say these are something which we feel as a caring cancer community need to be included, which includes technology, which includes infrastructure, which includes genomics also. Like I mean, now we have we that's not a new thing in cancer only.
For
There's
sure.
a whole lot of things has to be there. I think, and along with the 15 Finance Commission, there is an integrated public health lab systems are being thought about and not thought about. It's investment is happening. Why can't we bring in the basic cancer testing decentralized to the CHC level and the PHC level? There's a battery of tests already been defined. And some of the tests which we are now discussing about, which is relevant to the cancer care, should be at that level, rather than waiting for another state to come in after 1.5 months. So I think there's a lot of advocacy need to be there. And this is the right environment and right. And mass screening is something which we learned from COVID also. So probably some lessons from the COVID post pandemic infrastructure investment we need to be leveraged in this area. Thank you so much.
Thank you, Dr. Shibu, for sharing your experience and answering my question before I asked about, the implementation of AI, because there is more and more talks about it, and we know that thermal screening is something that has started. In the last conversation, we also had one of the clinicians talk about virtual colonoscopy, instead of having an invasive procedure. So I think bringing in more of the AI aspect to the screening might be one way to, to overcome the barriers of geography and personnel skill, that we need to operate some of these machines and radiology machines as well. The common themes, if I want to summarize what we have talked about in the last 1 hour, one, I think is having more and more, multi-centric approach. One from research, also from the perspective of having multiple organizations, government and private come together at various levels, the state, the central, as well as, tertiary levels come together to overcome some of these barriers. Second is, of course, advocacy for patients and advocacy for screening. So this can only happen by awareness, which I think all of us are doing from our work, but also to start thinking, from our own perspectives about how can we start educating the society around us. I mean, why wait for the government to push when we can start doing that at our own levels? So is to look at how can we do more public awareness amongst the society that we live in, and that the word of mouth would spread. I think people are more and more open to medical care and to genomics and to overall healthcare. Thank you, post-COVID, that probably has been one of the lessons we'll all learned. So is to bring that awareness to our patients, and that will also help us reduce the stigma and the fear that people experience. And I think the third most important thing is to, bring in technology. I think government has shown us a great example on how can we fight using technology, and thankfully, because of the integration of technology in 4G and now 5G in India, I think we have more access to people, right? Even if geography is a barrier. So how do we bring in technology both in terms of screening, in terms of imaging, and also in terms of treatment and connecting? I think telemedicine is one of the key things that we want to definitely, also discuss and help. Even clinicians get more and more comfortable with it, so that we can overcome some of these barriers of expertise as well, right? I think we are up on our time today, and I would love to keep going on with this conversation, but our time is limited. So I really want to thank each one of you for a very insightful discussion, and definitely, great experiences that you all bring in. I'd love to hear more about your work and, continue to see your work. And I hope that we all can come back again in some time and, see how we can progress on all these 3 points that we summarized today. Thank you, each one of you, for this wonderful discussion today.
Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you, everyone. Bye.